We are live.
Good evening, everyone. Welcome to episode 57 of the Fogsi Presidential Initiative Gyan Pravah podcast series. Today, we're going to be embarking on an insightful discussion on a topic that's important in women's health. That's breast health in today's era. Today, we'll be delving into many dimensions of breast health in the modern era. We'll be talking about why early detection is a game changer, lifestyle factors, the role of genetics and screening, and even the emotional and psychological aspects that often go unnoticed. This conversation is about empowerment. It's about replacing fear with facts, silence with support, and uncertainty with clarity. Whether you're in your 20s or 60s, whether you're a patient, a caregiver, or simply someone who wants to be more informed, this episode's for you. So settle in and get ready for a thoughtful, insightful, and inspiring discussion. Today, I have Dr. Karishma Kirti with me, who's going to be talking about this. But before I give a formal introduction of her, I have to introduce another brilliant, beautiful, and visionary lady, our Foxy president, Dr. Sunita Tandulwadkar. I know there's lots said about her, but one has to remember she's a pioneer in reproductive medicine. She's the president of Foxy 2025, and she's been the forefront of innovation, bringing groundbreaking advancements in IVF as well as gynecological endoscopy. She's the force behind India's first stem cell baby. That's a testament to her dedication to pushing boundaries. Beyond her achievements, she's an inspiring mentor, a passionate educator, a true visionary in women's health. This year, she's given all of us chairpersons an opportunity to express ourselves and mold ourselves into leader. As she always says, I want to create leaders, not followers. Sunita ma'am, thank you for this opportunity, and I want to hand over the dice to you, hear your inspirational words.
Thank you, Rohan. Thank you. You always use your words with so much generosity, and I'm overwhelmed. I don't know whether every word is true for me, but I enjoy listening those words. Rohan, you always come out as a very promising gynecologist, ART consultant, and a colleague, you can say, whom you can depend, your team members. The Foxy presidency is not one-man job. It is the entire team, your dreams, your projects. They also can give inputs and they together make it grow like anything. And you played a very important role. And I knew when you took a committee, I knew that you are going to work with me. So I'm so glad, Rohan, you are in my committee. I see in you, Rohan, the leadership, whether it is because of genetics or whether it is because of your environment or whether it is you have developed yourself with that. But definitely, I see the leadership quality and keep that one. Another very important quality of yours is not only you are thorough with your subject, you are well prepared, but you have a sound knowledge also. So that makes it very different. Today, the breast health, such an important topic. And I'm so happy that Karishma was ready to join. And it's so important, Karishma. We don't know many things. They may be simple, but just by hearing you, I'm sure today everyone in the country will be benefited. I think our podcast goes on all social media. So today, I think non-medicos who are the viewers will also get benefited with you. Just to your information, we are for the breast health promotion, we are doing Kashmir to Kanyakumari Yatra. We are launching in April 1st week in Kashmir, and it will be ended in Kanyakumari mid-year. So in one of that, we'll definitely love to have you, dear. Thank you so much, Rohan. And as the protocol said, after listening to Karishma's all, I will be joining and listening to you from another. And just imagine how beautiful it will be, two of you officially engaged into the dialogue of breast health. Thank you. I don't think you have discussed that enough any other time.
Absolutely. Madam, it's always wonderful to hear your words. And again, thank you for the opportunity. Thank you for always making us think out of the box. This is one of your out of the box series, which has given us the opportunity. And I hope we're doing justice to this entire platform of yours. Thank you so much.
Rohan, 1 minute more. Usually, I see the committee chairperson gives the excuse that we don't have funds, we wish to do so much. So this time, writing of the book, I'm giving you. You want to do the CMEs? I'm giving you CMEs at platter. Podcast, I'm giving you on platter. So 356 podcasts have been given to you all. And I'm so amazed. It was really true that the committee chairpersons were struggling to get the funds because the way you all are performing, and the podcast has become one of the most important agenda. Thanks to you all 30 people. Thank you.
Thanks to you, ma'am, for the opportunity, without which we can't really showcase our gifts. Thank you so much, ma'am. Thank you.
I would love to hear about Karishma.
Definitely, ma'am. So now I'm going to introduce my guest of the hour, Dr. Karishma Kirti. She's a consultant breast specialist and oncoplastic surgeon at Jaslok Hospital and Research Center, Mumbai. And she's also a lecturer of surgical oncology at the D.Y. Patil Medical College and Hospital. She's received a breast oncology training from the Tata Memorial Hospital, Mumbai, and L'Institut de Soins, Paris. I'm sorry, Karishma, if I've mispronounced that, but she holds a master's in breast oncoplasty also from the United Kingdom and is a fellow of the European Board of Surgery in breast surgery. She is Dr. Karishma also specializes in breast cancer surgery with a focus in breast conservation and reconstruction. She also treats benign breast diseases and advises on screening, awareness, and hereditary breast cancer genetics. Her field of interests include oncoplastic breast surgeries and young women cancers. She's an author of multiple chapters and has published research papers in prestigious peer-reviewed journals. She's given talks, argued debates, sat on panels in various national conferences, and has presented her work internationally as well. She's a reviewer of manuscripts for the prestigious Indian Journal of Surgery, and recently she's also won the Economic Times Onco Frontiers Award 2025. So Karishma, I'm so happy that you could make it for our podcast, our Gyan Pravah podcast, and thank you for being here.
Thank you
so
Karishma.
much. Thank you, Dr.
And thank you for coming on a Fogsi platform. It's honor to have you, dear.
It's a pleasure. It's a pleasure. I love working with Fogsi because I think it's so important. As I often say that, gynecologists are the first point of contact for women, whether it's gynec related or breast related, because, they all come under the same umbrella. So I'm happy to always connect with Foxy because I feel like Foxy does so much. So many programs which are breast related, and I'm so glad to see that we're also now doing things for the general population. And I'm so excited about your Kashmir to Kanyakumari. It's amazing, all the different things you undertake. That's great.
Thank you. See you soon.
Thank you, Sunita, ma'am.
I will join the other link.
Yes. So Dr. Karishma, I know this is a little bit of a formal conversation as per our usual conversations, but can you let us just know about your journey? What's inspired you to become a breast oncosurgeon? And why do you choose this care specifically? And what's your motivation behind this?
Thank you so much, Dr. Rohan. It's a pleasure to be here on this podcast with you. What happened? Why did I choose breast surgery? I think a lot of it was serendipity. What I wanted to do really was general surgical oncology, and I joined Tata Memorial Hospital as an observer in the breast unit, because breast unit there is always short of people. However, from there on, I graduated to become a fellow and an SR, and I did notice that a lot of my colleagues who were residents there were doing general surgical oncology and then specializing in another field, whereas breast oncology was something that I had already done for a year by then, and I was developing an interest in it. So no, I wouldn't say it was my first plan at all, but I thought I would do general surgical oncology because I'd do something new every day. But I happened to be in the breast unit with amazing teachers, a very women-led strong department as well. And the other thing was that breast surgery in itself is changing quite a lot right now. So if we have plastics coming in, and it's not just very straightforward mastectomies and VCT anymore. But there is an element of plastic. So it's a very exciting time in breast surgery. And I think that was also one of the reasons why I developed an interest in it, because I was always divided between surgical oncology and plastic surgery. So it was the best of both worlds for me.
I think you've just talked about how your love for the field has just built over the years as you kept training, you understood that this was your calling, and I think that's amazing to hear. Well, now to shift on, I just want to talk about breast cancer. Now, if we see that it's one of the most common cancers in women, um, if you look at a few decades ago, if you go to see it, it wasn't the same situation. Is there a reason why breast cancer has increased over the years?
Yes, so breast cancer is not one of, but it is the most common cancer in women worldwide and in India. And according to more recent projections, they say that could probably be the most common cancer in males and females combined. Because a lot of it's because of a couple of reasons. One is that the head neck cancers, and even some of the gynecological cancers are going down because of the vaccines and reduction in tobacco for head neck. And breast cancer is two things. One is that we are diagnosing a lot more. So because of the screening in the Western populations, a lot of disease which would have earlier gone unnoticed, or would not have maybe developed into something more major, is getting discovered, is getting treated. And the other thing is, yes, we are moving towards a lifestyle which does increase the risk of breast cancer. I mean, we could talk about all the risk factors now.
No, so I understand that. I think the most important thing is that people, I think, are getting more aware. They're being more understanding about the screening part of it. Is that possibly one of the main reasons
Definitely.
why we're being
So,
able?
yes, yes. So definitely, as I said, that we are screening more, so we are finding more. And if you look at 20, 30 years back in a village in India, maybe somebody would just develop breast cancer and die of meds and nobody would even know. So we are recording more, we are getting more data, and that is across the board. But for breast cancer also, we are seeing more of lifestyle changes, etc., which are causing an increase in the risk.
So could you just enumerate some of the signs and symptoms women shouldn't ignore? Like if they find any of these, when should they actually be either going to their breast surgeon or gynecologist?
So, very simply, and I wish it was different, but the most common symptom of breast cancer is a painless lump. And that's why we see so many patients come to us at a much later stage, because it is a painless lump. If it was a painful lump, I feel like a lot of patients would come earlier. So the most common symptom is a painless lump. The other thing is changes in skin, for example, a redness in the skin, which does not go away with antibiotics. Then an orange peel-like appearance of the skin. Other changes in the skin, like a wound or an ulcer that is not healing with local treatment by a normal physician. Then nipple changes, for example, a retraction in the nipple, scaling of the nipple, like you get a scab when you get an injury, that kind of scabbing of the nipple, a discharge from the nipple, which could be bloodstained, yes, everyone knows, but even a clear, profuse discharge from one nipple, which, is spontaneous, not like when you really press it and you get one dot, not that, but on its own, it's coming out. These are some of the common symptoms. Very, very occasionally, you can even get an axilla, which is a lump in the armpit without any symptoms in the breast, or a neck lump without any symptoms in the breast. So, those are some of the things that one should
So
watch out for.
absolutely. So what you're at the end of the day saying that you need to be a little bit self-aware also that these symptoms are present, the signs are present. So could you just let us know that we know that breast self-examination is something that we've been advocating, I think, over the last 10 years, in fact, even longer, I'm sure. It's just that from what age should women actually start doing it?
Right. So, one of the things is that the first part of cell breast examination is actually learning the symptoms, which is what we talked about. And the three parts are actually learn, look, locate. And we'll come to that. And learning means learning the symptoms. Looking is when you look at yourself, and locating is when you actually touch yourself to feel for any of the symptoms that we talked about. And very often people think that, oh, only examining yourself is cell breast examination, but it actually consists of these three parts. When should people start doing it? As early as 18 to 20 years. So,
Oh,
as a mature woman, you should know what breast cancer looks like. You should become aware. And I'm talking about an average risk woman. I'm not talking about if you have a strong family history of breast cancers developing from an early age. No. But even then, cell breast examination is something that you started around 18, 20 years of age. You should do it every month. And you should do it 5 to 10 days after your first day of period. So if I get my period on the first, then the best time to do is between 5th and 10th, mainly because that is the time when your breast is the softest, the least painful, and it's just easier to examine yourself. Also, some people have something known as fibrocystic changes in the breast, which are like little lumps, bumps, nodularity, which become more prominent just before periods because they are hormone dependent. So sometimes people can mistake that for something in the breast. So another thing is that if you find something in the breast, you can wait one period cycle. So if you find some like a lump in your breast just before your period, maybe wait for your period to come and go and see if it's still there. And if it is still persistent, then yes, definitely you should meet a doctor.
Okay, that was something even I'm learning today for the first time. I think that's quite an insightful look into it, because a lot of our patients, when they come to it, come with a lump, our first thing is immediately get a mammography or get a sonomammography done. That's also a big dilemma, which we end up not understanding whether to go in for a sonomammography or an X-ray mammography. So what would you suggest? At what patients should be considered for sono, while those should go for the standard mammography?
Yeah. I'm very proud of you for knowing that sonomammography is different from X-ray mammography, because a lot of the times we get patients referred who said, "Nahi, we've done sonomammography," which they think means sono and mammography. Well, mammography is just imaging of the breast, and an X-ray mammogram is what you traditionally call a mammography, and a sonomammography is an ultrasound of the breast. So, in whom do you do what? So, it's always first choice of investigation in someone around 35 years of age and under. You would prefer to do an ultrasound first, simply because a mammogram would be very dense in them. And in someone older than 35 years of age, and that's usually our cutoff, sometimes it can be 40, you do a mammogram as first choice of investigation. In someone who's pregnant, also I'd probably do an ultrasound first rather than going in for a mammogram with abdominal shielding. So that's basically the cutoff, and mainly because mammogram is more clear and more sensitive in someone who's older, whose breast is less dense, which means their breast comprises more of fatty parenchyma rather than dense breast tissue, which is seen in premenopausal women.
Absolutely. And I think thank you for clarifying that, because that's something that we end up always getting a little bit of confused with, because thinking that a lot of women keep saying that a mammography is so painful, it's not comfortable to do. So we are like, go ahead, get a sonomammography done, thinking that it's going to end up giving us the same results. But this clarity with a difference between the sonos and the standard mammograms actually makes a lot more sense, because that's actually going to give us answers into what the patient's actually suffering and give us more accurate answers than anything else, rather than having them first undergo a sono and then, because I think usually most of us do end up preferring doing a sono mammography rather than a standard X-ray mammography, thinking that it's going to give us equally good answers, but be less
But
painful for the.
yes, yes. But often enough, yes, they do overlap. But there are some things like DCIS, which present as microcalcification and things like that, which are only picked up on a mammogram. And that is why mammography is still the first choice of investigation in the patients in whom we are more suspicious of actually having breast cancer.
So just want to ask you, because now considering that all of us listening to this podcast, rather majority of us on this podcast are gynecologists. When a patient comes to us and we're doing a regular checkup for them, do you think a mammography should be made a regular part of it?
So I think anyone who's 40 and over, you can ask them to do a mammography as a part of screening. And this is something known as opportunistic screening, because a lot of the patients we see and are in urban areas are very often women who have had children late or have had long-term use of oral contraceptives or not breastfed. A lot of these urban related or overweight, and these are some of the symptoms which some of the risk factors which are seen in breast cancer. And we do recommend opportunistic screenings for women who come to our OPD for other reasons as well. Because clearly, I mean, doing a routine population-based screening is not really the priority in India right now. It can't be. We have a lot else going on. But opportunistic screening is something that we can look into.
Definitely. So you were talking about the urban group, that the urban class is the one that where you end up doing opportunistic screening more. Do you think there's a rather gap or about breast cancer awareness between the urban and rural?
Definitely. So,
So how big is that gap?
it's a huge gap. So if you look at in US or UK, they say 1 in 8. Now they've started saying 1 in 7 women develop breast cancer in their lifetime. In India, that risk is about 1 in 24 women in urban India and 1 in 64 women in rural India. So
Okay.
it's about, lifetime risk of 12% versus 4% versus 1.5%. So it's much less. It's less than half of what it is in urban India. So yes, urban people living in metros do have a higher risk of developing breast cancer, and that is probably not really related to the fact they live in metros, but probably due to the lifestyle they lead because they live in metros. And can I just talk a little bit about the risk factors? I feel
Of
like
course.
it's
Yeah, yeah.
always circling back to the same
No,
thing.
no, no,
I
in
know
fact, I
it
was
is
going
one
to
of your
come to you
future
because
questions.
you were talking about the lifestyle factors. I was in fact going to tell you that please could you tell us the lifestyle factors as well?
Definitely. So, I'm going to, when we look at risk factors of breast cancer, you have non-modifiable risk factors, and these are things we cannot change. Simply things like age, increasing age increases your risk. Being born female increases your risk. If you have a family history or a known genetic mutation, that increases your risk. If you've had radiation for a different, like a lymphoma, in your childhood, then your risk is higher. And sometimes even having had some dense breast in a mammogram in later age, that can increase your risk. And these are things that you cannot really change. But coming to the more useful stuff, which is things you can change, things that you can do today to reduce your risk of breast cancer. And a lot of them are lifestyle related. So one is obesity, especially postmenopausal obesity. I know it's very difficult to lose weight in the menopausal age group, especially because your body is trying to get all that fat in to get the estrogen going. But that is the time that you need to lose it, because your body needs to when you have more fat, there is more estrogen exposure, there's higher risk of breast cancer. The other thing is exercising, and this is, of course, related to obesity, but it is also an independent factor for risk reduction in breast cancer. So if you look at two people with the same height and weight, but one is exercising and one is not, then the person exercising will have a lower risk of breast cancer. The
Okay.
other thing is your diet, of course, red meats, processed foods. You need to reduce that, and not just for breast cancer, for almost any disease that you name. Just eating fresh local produce is good for you, including flax seeds and omega 3s in your diet as well. And then other risk factors, and these are not very, very don't increase your risk by that much, but they are in the picture, and these are obstetric. For example, having your baby after the age of 30 years, not breastfeeding or breastfeeding for less than 3 months, having not having children at all, and this can be either something that you can change or something that you cannot. Then having a long-term use of oral contraceptives, and I always say this with a disclaimer that most of these studies were done with the older sort of dosages of oral contraceptives. But even the newer studies, which have been published in the last 5 years or so, which have shown that there is still a slight increased risk with the oral contraceptives, even the modern ones that we have now. And then hormone replacement therapy. I always feel like I'll get killed when I say these in gynecological forums. But yes, all combined hormone replacement therapy taken for a year increases your risk, increases your breast density, and taken for 2 years or more, increase your risk of breast cancer. And also it increases your risk of mortality from breast cancer. So it is something that I think should be used judiciously. And I think this is an important forum for me to say it.
So honestly, with the HRT treatment, what you're talking about, do you think that then we should be screening them a little bit more intensely if they have been put on HRT treatment?
Definitely, definitely. Yes, those are the patients that should have an annual mammogram, according to me. And patients who are on HRT, I think should, if you start with a full scale HRT, I think over time you can try sort of reducing it or moving them on to, sort of phase them out of it and only give them shortest duration, lowest dose for what works for them. And that is how we look at it.
Okay. Do you think that if we give local vaginal estrogen creams and things like that, that would reduce possibly the risk of breast cancer in these patients?
It doesn't reduce, but it doesn't increase the risk like a systemic HRT would.
All right. Okay. Thank you. I think those were some insightful viewpoints. And don't worry, all our gynacs are usually
I've not
very
covered
receptive.
alcohol.
Oh, the alcohol smoking, I think, usually ends up covering most of the cancers, even on the gynac front of it. So
Yeah.
I think those are points which most of our this viewers will probably know that smoking and alcohol would increase the risk.
Alcohol, yeah, but alcohol is very significantly connected with breast cancer. So just to put it out there.
Absolutely. So we've talked about the risk factors, we've talked about the different aspects which could increase your chances. Let's get to the treatment parts of it. Could you let us know what are the current more promising advancements in breast cancer treatment today?
Breast cancer treatment, okay, so a couple of things, breast cancer, the treatment of breast cancer is generally multimodality. So you have surgery, you have chemotherapy, and you have radiotherapy. And there are so many advancements in every field. So as we did speak about in the introduction as well, we have something known as oncoplasty in breast cancer, and that is taking plastic surgery techniques and with oncological safety, operating patients, yet still being able to maintain the breast mount, giving them that cosmesis, giving them that self-confidence and better quality of life, which is very important because our cancer patients, breast cancer is a very curable sort of cancer. So we have patients living for a very long time, and quality of life becomes very, very important when survivorship is it's an important part of survivorship, especially when the survival overall survival is fairly long. And the other thing is, of course, now we also have robotic surgery, and we have endoscopic breast surgery. And those are the things that are coming up. Do I think that every patient needs it? No, but I think that we're still looking at data, and I would still, we're looking at more people publishing the work they've been doing. Is it we have to just when we do robotic surgery or endoscopic surgery, as long as we are able to achieve what we do when we do an open surgery, which means when you do a mastectomy, we make sure that you do complete removal of the breast. As long as robotically and endoscopically we are able to do that, then the results are fairly similar. Okay. The other thing is, if you talk about chemotherapy, of course, I think everyone's heard about immunotherapy, and that is kind of like waking up your immune system to fight against the cancer cells that are present in your body. And that's the new thing, or the buzzword, which is there in as a part of chemotherapy, along with that targeted therapy. So there are lots of targets being seen on cancer cells, and specific drugs that are being made to target that. In CT, we are getting more and more precise, in the breast, making sure that the dose to heart and lung and the other important structures are as minimal as possible. So there's lots of new work coming up in different fields, which are present as a part of treatment of breast cancer.
Absolutely. You've been talking so passionately, especially about the advancements. However, you did talk about mastectomy at this one point. What I do want to ask you is, um, I'm sure patients, when they come, they're always a little bit hesitant or they're in fear of losing a single breast. So, what's your approach towards them? Like, how do you counsel them?
They are worried about losing a breast.
Yeah,
We have
because
patients on two ends of the spectrum. There are patients very occasionally who are worried about losing the breast. And so we have a lot of patients who are just take it out. Take it out. I am so scared. So we obviously counsel both ends of it. And there is more than enough evidence that tells you that as long as your patient selection is correct, then both the surgeries are equally efficient. If you do a breast conservation surgery in early breast cancer, it may be better than doing a mastectomy for that patient. And that is data that's come out in the last 2 years from Sweden. And, so I mean, and breast conservation surgery is not something new. The first breast conservation surgeries were done in the 60s and the 70s. And now we have 25 years of follow-up in those patients to tell you that breast conservation surgery, when used with radiotherapy, is equivalent to mastectomy. And new data that tells you that in early breast cancer, it might even be better than mastectomy. And so patients who are scared of losing a breast, fortunately or unfortunately, there are very few patients who are like that. And for a lot of our patients, we are able to conserve the breast. I would say at least 70% of the patients, we are able to save the breast either upfront or after giving chemotherapy. So there's something known as neoadjuvant chemotherapy, in which you give chemotherapy first, you reduce the size of the breast lump, you reduce the size of the axillary nodes, and then you do surgery. And this is especially important in patients that are triple negative breast cancers, in which all the receptors are negative, or in patients who are HER2 positive, who would really benefit from targeted therapy. And because these are the patients that respond really well to systemic therapy. So in those patients, we would give chemotherapy and systemic therapy first, reduce the size, and then save the breast. The other thing is that we can also use oncoplastic techniques, which is which is using a pedicle or a local flap, or using a flap from the back, or in some patients who have very disseminated sort of disease, which is in multiple quadrants, or we are not able to take out uh, oncologically safe margins after removing the lump, because saving the breast, saying breast conservation surgery, is not removing half the breast and saying, oh, I've saved the breast. No, after you are finished with your surgery, the patient or the woman should have two symmetrical looking breasts, that should be aesthetically sound looking. And so in some patients in whom the area is too large, we even do reduction of both sides to give that symmetrization. And in some patients in whom we must remove the entire breast, we are now doing skin sparing mastectomies and nipple sparing mastectomies, and creating the breast mount again at the same time. Now, this can be done using the patient's own tissue, which can be from the abdomen, from the buttock, from the back, or using any of the implants that are available. Um,
So yeah, that actually was quite overwhelming to hear for myself. Like even when we're talking, I can imagine the amount of counseling that takes in for the patient, because in order to actually make them understand the entire process, it can be. So I'm sure usually you're taking a multidisciplinary approach in terms of even having a psychologist in play during the entire counseling. And I'm sure that it ends up becoming the radiologist, the psychologist, the surgeon themselves, the medical oncologist, who would eventually come together and end up making the plan for the patient. Uh,
so
Yeah.
yeah. So I'll tell you, I mean, maybe psychologists may not always be a part of an MDT for us, because I mean, we don't have so many resources available all the time. So what we do is that we definitely have a pathologist, radiologist, med onco, radiation, and the surgeon. And these are the five people, and the plastic surgeon if required. And these are the 5 or 6 people that are really, really required. And the other people, we do sort of refer patients to them as needed. So when we see a patient with breast cancer, or when we see when we break, which is a part of what we learn is breaking bad news. So when we announce the diagnosis to the patient, we do check them for any distress signals. How are they coping with the news? And based on that, we do refer some patients to a psychologist, but not everyone, and not everyone also needs to be. So it's a call that we take based on how the patient takes the news and how they go through treatment. It's not once, oh, I've decided this patient doesn't need it. They may need it as they go through treatment, as they go through chemotherapy. Are they really recovering well? Do they have some random symptoms which don't really fit the bill? So those are some of the things that we take into this thing, and we ask them some questions about how they are coping with it. And very often patients come and tell us how they're going through it. Sometimes, they have very unexplained fatigue, which cannot be related to anything that they're going through, any treatment. So, just picking up on those small signals, and selecting patients that need to go in for additional counseling, that's also a part of when we see patients and what we decide.
Fair enough. Dr. Karishma, you've been talking about these cases. I'm pretty sure you're seeing tons of cases every day, every week, through the month, through the years. How do you unwind? How do you stay centered amongst all these high pressure nature of your work? Because I can understand there's quite a bit of morbidity involved with the cases, but what do you do to unwind?
One is that I am blessed with a slightly less mortality filled cancer. So we have patients who do really well. We have very happy patients coming back years and years after follow up. And a part of seeing follow up is also at your work where you're supposed to not be happy, but you're happy. So of course the work brings you happiness, but it is a high stress job for most doctors. It is a job which is a high stress or a high pressure job, but you see patients who come back and your success stories also help you feel really relaxed and happy. And then you come home and we have a lovely family and two lovely dogs and a 6-year-old who is, the beginning and the end of all joys in my life currently. So I think that's also so important. And being able to sneak away for a couple of days here and there and taking a break with the whole family, I think that also helps.
Dr.
So,
Karishma, you can put in
what
a
about
word
my
about your
guilty
husband as
pleasure?
well. You can talk about your husband as well a little bit.
That's why I said family. Sorry. We
Yes.
are
What's your
like,
guilty
you
pleasure?
are so important. Talking about my guilty pleasure, my K dramas.
Oh, fair enough. Fair enough.
Some
So,
mindless TV watching also helps from some time to time.
all right. So now we're coming to pretty much the end of the podcast, and I want to just put across a few questions to you, which would be sort of a rapid fire, but not really at the same time. So could you just tell us one myth about breast cancer you'd like to bust right now?
Wearing underwire bras causes cancer.
Oh yeah, that was something that
That is so
we,
common.
yeah,
People ask me that even now. Young
oh,
girls asked me that last week.
in fact, even for us as gynecologists, especially in IVF, when we're talking about it, and if they've had a history of cancer, they're like, I've stopped wearing underwired bras for the same reason. And we have to try and explain to them that that is not the situation.
Yeah.
Uh, your message to young women, especially in India, on breast health and empowerment?
Touch yourself. This was
Fair
an
enough.
actual campaign where they said you must examine yourself. So it's a self breast examination campaign. So
Absolutely.
examine yourself every month.
And lastly, what's your vision for breast cancer care in India in the next 5 to 10 years?
Breast cancer care in India. My God, this can't be a rapid fire. This is such
It's
a
not. It's not. This was something for you to actually give your take-home message to all our viewers.
I think what we not just in the 10 years that I've been in practice, I find that already we see a very different set of patients. And that might also be because we moved on from a more government setup or a more charity-based setup at our hospital and moved on to a more private practice. But we see women with smaller lumps and earlier disease. And I hope that that momentum sort of continues and we are able to see disease that we can catch early and cure better. And with the rise of systemic therapy, I do also see that surgery becoming less and more controlled. But also I hope that it doesn't also become just to de-escalate one, we shouldn't escalate the other thing more. So I hope that we're able to reach a very personalized sort of treatment of breast cancer. And I hope to see that in the future.
Thank you so much. Thank you so much, Dr. Karishma. You've given such a beautiful and insightful view into breast health in today's era. And it's something that's been taken up by our own Fogsi president, Dr. Sunita Tandulwadkar, especially with the Kashmir to Kanyakumari Yatra. And her invite has extended it to you as well. So we're looking forward to you being a part of that Yatra as well. Dr. Karishma, I know you've had a very long day, and thank you for taking out this valuable time to be a part of the Gyan Pravah podcast. That's every day at 8 p.m. And thank you to Dr. Sunita Tandulwadkar, our President, Fogsi 2025, for giving all of us this opportunity to be there. Thank you, Dr. Karishma, and we look forward to having you on other podcasts and other involvements in Fogsi as well. Thank you very much. Good night, everyone.
You. Thank you. It was a pleasure to be here. Thank you, Dr. Rohan.
Thank you. Good night.